Welcome, everybody. It's a couple minutes past our start time, so I think we'll go ahead and get started here. It's my pleasure to introduce Dr. Victor Prieto, who is a pathologist, dermatopathologist, and bone and soft tissue pathologist. He's the chair of the Department of Pathology at MD Anderson, and we were very honored to have him step in as our S1801 pathology chair, which turned out to be, as you guys know, such an important role for this neoadjuvant space that we're in. So Victor's going to kind of touch on what neoadjuvant assessment looks like in melanoma specifically, and might even highlight some of the things we're looking for and looking at S1801. So Victor, thank you.
Thank you, Sabna. Thank you, everybody. Just rather than to be outside enjoying life, which, by the way, today is a beautiful day. Coming from Houston, this is probably paradise weather-wise. So thank you, Sabna, for inviting me. Thank you, Society, for just asking us to show our experience. And I wanted to start a slide rather than leaving to the end at the beginning, because this is the group that developed the first analysis on the neoadjuvant the studies in melanoma and how to evaluate the histological response. I'm a consultant for Merck, Castle, and or Lucent, but it has nothing to do with what we are presenting. And I wanted to acknowledge Dr. Michael Tetzlaff. He is right now here in UCSF, but as you know, or probably you know, that he was with us in MD Anderson. So what we wanted to go over is how the tissues are evaluated and how we're trying to gather the information in order to be able to predict the response. We are coming late to the game, if you want to, because this was started probably, and the first organ was in bone with the osteosarcoma. And it was actually precisely MD Anderson at Kevin Raymond when he was at MD Anderson, who developed the study and came up with a magic number of 90%. So if osteosarcomas were treated and more than 90% of the tumor became non-viable, those patients had a very long survival. After that has been breast, has been other tumors, and melanoma is coming to the party. This was the study, and you see some of the people are included in the acknowledgement list and are included there. So the first thing that you have to consider is that not all histologic evaluations are the same. And first, what you have to determine is how you're going to process the study. Because if you are familiar with histologic examination, the way we do it is we take the tissue out. There's sampling of the tissue, because if you have a tumor that is 10 by 10 centimeters, that would be probably 1 million of slides, because we cut sections that are 6 microns or 5 microns, you can put 201 millimeter. So just imagine if you had to examine everything, it would be impossible. So there are different schools of thought. For example, sentinel lymph nodes, they are examined entirely. So if you have a sentinel lymph node, the entire lymph node is examined with sections, whether they are perpendicular, Bread-Loffin, or they are longitudinal, but the entire tissue is processed. But these are not sentinel lymph nodes by definition, because those patients have clinically positive or likely histologically positive lymph nodes. So for those, the first thing is, let's see. Well, actually, let me do it this way so you both can see it. So all lymph nodes are examined, which means that at least a section of each lymph node will be evaluated. And with the distinction that if lymph nodes are grossly positive and they are larger than 5 centimeters, which the majority of those are going to be matted lymph nodes, one complete cross-section is included from every centimeter. And this is not a magic number, but this is what is used particularly for soft tissue and on ovarian tumors, because it has been examined that if you review at least one section per centimeter of the tumor, it's very, very unlikely that important areas are not missed. So for example, if you examine liposarcoma and you want to determine if there is dedifferentiation, which conveys a worse prognosis, or if you are looking at an ovarian tumor and most of it is a borderline ovarian tumor, but want to make sure that you don't have the invasive component, if you do that every centimeter, that's enough. So that's the reason why there is this cutoff. If the tumor grossly positive is equal or larger than 5 centimeters, it's required to have one section per centimeter. And if it is smaller than 5 centimeters, the entire lymph node is examined after bread loafing. So from that original study from Tetzlaff and the group, the tumor bed was defined as the area of tissue occupied by the way, I don't think it's, let me make sure that you can see it. Can you see the mouse? Yes, okay. So the tumor bed was defined as the area where the tumor was supposed to be. And what I'm saying is was supposed to be because there's a combination of if there's viable tumor, if there is necrosis, if there is fibrosis, or if there are melanophages. So just imagine, and I'll show you a few images, that if you have a tumor that was a 2 by 2 centimeters, but 90% of the tumor is necrosis, still the original tumor was a 2 by 2 centimeters. So that's why this specialized reviewing is attempted, because and if you are familiar with the cases of some of the reports that you have received, it says no tumor identified, only macrophages, or no viable tumor identified, only necrosis and melanophages. And I will show you a few images to see how this varies between cases. And then the second is that how to define it. The original study, and again, I'm just going by the numbers that were included, was a pathological complete response, was complete absence of viable tumor. So there was either necrosis or fibrosis or melanophages. Pathological, it should be pathologic. Partial response, PPR, defined as equal or minus than 50% of the treated tumor bed occupied by viable tumor cells, and non-response that more than 50% of the tumor bed that had viable tumor cells. So what do we have in those areas? Viable tumor cells that they can be in different morphological phenotypes, or the tumor cells can be completely gone, as in the third panel, or being replaced by pigmented macrophages. And by the way, the synonym would be melanophages, because a melanophage is a macrophage that has melanin pigment. Or it can be replaced by fibrosis. Typically, fibrosis is seen later on. So the first thing that you see is necrosis. Depending on how much melanin pigment those melanoma cells had, they will be melanophages. And after that, there's replacement by fibrotic areas. And that's basically the same as you would have in a scar. So in a case like this one, it's very easy to see what the tumor bed was, because this is a large primary melanoma, one of the series of the 1801. And even at this power, you can tell there are different areas. So there are areas like this one that have a lot of brown color. That's melanin pigment. But melanin pigment can be seen either in the tumor cells or it can be in the macrophages, the melanophages. We see areas like this one that is almost like abstract painting, because we have a rim of brown color with a center area that is pink. And we'll see in a moment that this is necrosis surrounded by macrophages. We see other areas in which there is a combination between a little bit of brown and a little bit of pink, and those are going to be fibrotic areas. Now, I was telling you that this is a primary melanoma, and we can see that it has the hallmark of in situ melanoma in the overlying epidermis. But let's go again in the deep areas, and we are going to concentrate in the different areas. And why is this important? Because just imagine the size. This is probably 1.5 centimeters in the width, and probably by 1 centimeter deep. So in this area, which is relatively small, there are multiple areas. So that would be important, because if you do only a biopsy, let's say that you do only a throughput or a punch biopsy, if you end up having this, it's going to be primarily necrosis and melanophages. If you end up in this area, it's going to be a viable tumor. And if you end up in this one, it's going to be fibrosis and melanophages. So let's go a higher power. And this area in the center has all four. So there is necrosis, which is this pink area. And if you notice, the nuclei, which are the tiny dots, are not dark. So if you compare a nucleus in here, that's a melanoma cell. And the nucleus is dark because it has hematoxylin, and hematoxylin is a purple color. But if you look at the nuclei of these guys, there is no hematoxylin because the nuclei are dead. Those cells are dead, and they have a ghost of a nucleus. So we have necrosis in this area, surrounded by these darkly pigmented cells. Those are melanophages. We have an area of this in which there are tumor cells, they are viable. And then these, I can barely see, here we go. These spindle cells, those are fibroblasts. So in this field, you have all the four components. Now, if you had to count only this, you would say that it's a 15% of necrosis, approximately 25% of melanophages, 50% of tumor, viable tumor, and 15% of fibrosis. But then to make it even more complicated, when you have a larger melanoma like this one, it's likely that you're going to see different areas with different morphologies. So it's not so easy to tell apart if you're looking at a macrophage or a melanoma cell. So all the images I'm showing you in this slide, they're going to be from the same tumor in different areas. So those are tumor cells. Those are tumor cells, viable. And those are tumor cells. All three areas, 1, 2, 3, they are tumor cells, but all three look different. The last one has a ton of melanin pigment. The second one has very little melanin pigment. And the third one has a combination of melanin pigment, fibrosis, and non-pigmented melanoma cells. Other areas have more prominent necrosis, as in this one. Notice how this periphery, those are viable tumor cells that have a dark nuclei, compared to this, in which we don't see the nuclei. So that's a necrosis, and we have the crown of melanophages and a higher power, showing how you have a combination of cells that are dying in the center. Here we go. The darker nuclei, those are viable melanoma cells. They are surrounded by the pink melanoma cells that don't have a nucleus, so you only see the ghost of a nucleus. Now, I show you a tumor that had at least 50% viable melanoma cells. And as Samna, Dr. Patel was mentioning this morning, we don't know what the repercussion of this fact that you're going to see. So the same patient that had 50% viable in the melanoma, primary melanoma, the lymph node is this. So we have a rim of purple. Those are the lymphocytes. There is a rim of viable lymph node that is at the periphery. But the rest of it is brown and pink. And please notice that the brown and pink is merging with the adipose tissue. The adipose tissue is the white stuff that is at the periphery. And because fat, when you process the tissue, disappears, is extracted, and you only have the holes of the adipocytes. So this is a lymph node that has been bisected. You have the two images, and almost the entire lymph node is replaced by those areas that are pink and brown. Well, there was not a single melanoma cell viable in those. Remember that I showed you 50% of the primary melanoma? The metastasis was gone. And the way that we can do to prove that they are not viable melanoma cells is because when you do SWOG, which is a nuclear marker, there's nothing here that looks like a nucleus. So basically, this is debris, that those are melanoma cells that are dead and that have been phagocytized by macrophages. Same patient, a different lymph node, that we have areas of necrosis, fibrosis, this, and melanophages that had no viable melanoma. So, as Dr. Patel mentioned this morning, are we going to count this as what we see in the primary melanoma, or are we going to count it as what the metastasis is? If you think about it, the primary melanoma is gone because it's been completely resected by the surgeon. So it may not be important if the primary melanoma was not completely eliminated by the neoadjuvant, because what it was completely eliminated was in the lymph node. And this is something that we are, as soon as we finish the evaluation of these patients, we'll be able to see. Now, I showed you something that was relatively easy because it was viable melanoma, it was necrosis, melanophages, fibrosis. And the other one that I had just either necrotic tumor cells or macrophages, and we were able to prove it with SWOG. But other areas are like this, in which we have, what is my mouse? Here we go. There are darker cells, that those could be fibroblasts or could be melanoma cells, surrounded by the pink areas, that those are fibrosis. So immunohistochemistry is very helpful because it shows that many of the darker cells that they went in the middle of this area are pan-mel positive, meaning that they have the antigens characteristic of melanoma cells. And they have SWOG, which is a nuclear marker that is also characteristically present in melanoma cells. So therefore, that particular lymph node had extensive necrosis and fibrosis and only small areas of residual viable melanoma. But can we go to the extreme? And this will be the extreme. And this is why the evaluation has to be done by a pathologist that is familiar with this situation, because if you look at this, there is nothing viable. It's just only pink fibrosis, what is described as hyaline fibrosis. And that's what you typically see either in a keloid or in a long-standing scar. But this type of fibrosis means that there was something else before. And in the context of this particular patient, it was melanoma that has been completely eradicated in this lymph node. Just to highlight the presence of this fibrosis, this is another patient. It's a lymph node that we see the periphery, the rim of normal lymphocytes, and this is completely abnormal. So the whole lymph node should be like this, and the only thing we see here is pink, which is fibrosis. We have extensive fibrosis, but please notice that we have two areas. We have a basically pink area and areas that have more purple. The purple means that you have lymphocytes or cells, so they are nuclei. We go a higher power and we see that some areas have the pink of the hyaline fibrosis, and other areas what we have is a lot of cells associated with the collagen. So this is what is described as proliferative fibrosis, or it should be the early stage of fibrosis, and this will be the latest stage of fibrosis, which is the hyaline fibrosis. The same patient had in another lymph node. So the first lymph node had no viable tumor cells. This other lymph node has this area, is a small nodule that even at this power, you can tell that is different from the rest of it. That's normal lymph node. These light areas, those are follicular geminal centers. The darker area is the mantle of the follicle. And then this obviously looks different from the rest of it. That's maybe melanoma, maybe something else. When you go higher power, you see that you have round cells, that they have abundant cytoplasm. And when you do immunomarkers, you see S1 SWOG positivity. So that's residual viable melanoma. And SWOG can help you to see even smaller areas like this one, in which that's melanoma associated with macrophages. So because only the positive cells that are with SWOG are melanoma cells, and the rest of them are macrophages. So just to highlight, what we're looking for is presence of viable tumor, tumoral necrosis, meaning that you can see the tumor cells, but they are dead, they are not viable. Fibrosis, that it can be either proliferative or early and late hyaline, and macrophages. And this has to add for a total of 100%. One thing that is important is that gross examination is crucial for this one, because if I show you this, and I measure on the slide, and it's a 1 millimeter, or if I show you this one, I only have one section that, as I told you, the maximum size that you can have is usually between 1.5 and 2 centimeters. That's all the tissue that you can examine in one slide. But this could be a section of a tumor that is 5 centimeters. So that's why gross examination is very important in the evaluation of these tumors. And what does the pathology report looks like? Well, so in one of these cases, it's a melanoma with fibrosis and a mixed lymphohistiocytic aggregates. The largest tumor dimension in that particular case was 5 by 3 millimeters. And in this particular case, immunohistochemistry was used to confirm the presence of viable melanoma cells and the adding up of the percentage of viable tumor, necrosis, fibrosis, and melanophages. But is this everything we can do? Well, as I mentioned, we still don't know how much contribution is going to be. Are we going to have an average? Is there going to be an index lesion in which, if you examine only that lymph node, excuse me, or only that area, will there be enough information to prognosticate what is going to happen to the patient? Or it's a lymph node more important than the soft tissue metastasis? Or if the patient has a soft tissue metastasis that is 50% viable and 3 lymph nodes that are 0% viable, which one is going to be more important? And so we don't have the answers. And if you were this morning at the conference, you saw how important it's probably going to be the microenvironment, whether it's CD8, a PD-L1, PD-1, or another market that we still don't know, because that would be a very important evaluation, not only how much melanoma is left, but what is happening to the adjacent tissue. And I wanted to give some time to discuss all these findings, and with these 2 pictures of the beautiful city we are here. So thank you very much.
Great, great presentation, Victor, and thanks for what I wonder is, like, are these all like on a spectrum? Like does the tumor go through infiltration and then necrosis and then hyaline? And then what you're seeing here is that, of course, this is like a moment in time, right? And is it just one of those things that, early enough, like let's just say if you're going with the 9-week mark, that you might see something, but if you did it at 12 weeks, you might see something different. And you're just seeing that like dynamic kind of thing, but in one moment of time, or is it, do you think that these are pretty fixed things? And I mean, I think immunotherapy, I feel like it starts off someplace where you have T cells and then it kind of, spreads like a fire. So if depending on when exactly you're sampling and what you're sampling, you might see, like, I love those great examples of the discordance of responses, between skin and, yeah. So what do you think?
Well, it has to be a process, obviously. So it starts at some point and will end at some point. So if it is 100% successful, it's going to be 0 tumor cells, and then it's going to be left out whatever there was before. So if there was melanin pigment, there will be macrophages, and for sure there's going to be fibrosis. So the example I showed of that lymph node, that the only thing that was the dense fibrosis, that's perfect complete response, correct? There was not even melanin left because everything else had been removed. Now, that's a very important question, but may not be important to know why, correct? Because remember what I was mentioning about the osteosarcoma. What is important is that after you treat it, at the point of evaluation, if you have more than 90% dead, that's fantastic. So are we going to be able to do that in our cases? It may not explain the mechanism, because we don't know if it is only the lymphocytes or if it is a damage to the vessels. Because if you think about it, it's very difficult for lymphocytes to be able to eliminate all, because we are talking about millions of tumor cells, correct? Even though we have a lot of lymphocytes, but to eliminate those and only leave behind the fibrosis and the melanophages, I mean, that's a fantastically efficient. So is there a participation of vessels? And that's, so you have a component of ischemia, because that could be also too. Or are we recruiting macrophages too, in addition to the lymphocytes, and which macrophages are we recruiting? So the answer is, I'm with you. This is a picture of an evolution that we happen to have at that moment. That probably what is going to be important, and I'm just guessing, is that the faster that you get the necrosis and the fibrosis, the better it's going to be. But we don't have those data yet.
So like if you had it by 9 weeks, then that might mean something great. But if you hit it like much later, that might not be as great.
We don't know. Ask that question a year from now.
Mhm.
And the difference between sorry, I don't mean to. Oh, sorry. The difference between necrosis and that high line, what do we know about that? I mean, is that like a meaningful difference? Or, I mean, I know visually it looks very different, but in terms of outcomes, what does that mean? I mean, or is it the same thing? Or
in the study that I mentioned, that the one that correlated was not the amount of fibrosis, it was the amount of viable tumor that was left. If you had no viable tumor, that was great. If you had near complete response, and remember, the complete response was based upon the percentage of the tumor bed that was occupied by viable melanoma cells. If you had, and again, the magic 90% number, no, for osteosarcoma, if you had less than 10% viable melanoma cells, those were the ones that had the best response.
Really informative talk. Thank you very much for those details. 2 questions. One is, do you see different findings depending on the regimens that are used on your pathologic evaluation, meaning using BRAF/MEK, single agent immunotherapy, dual agent immunotherapy? My second question is there anything that you're looking for from surgeons when they send the specimens that are helpful in appropriate pathologic evaluation?
So the first question is not so much about the type of therapy, because whether you use an anti-BRAF, or if you use anti-PTEN, or if you use Nivo or EP, so the final effect is that you're killing the melanocytes, and you're going to have a combination of necrotic tumor cells, viable tumor cells, fibrosis, and melanophages. So I would say that more than the final image that you have is how effective it was. If you were able to kill most of the cells, or fewer. Now, the second question was?
In terms of how we label specimens, send it to you, anything that we need to pay attention to allow for you to be optimally able to
Yeah.
handle.
I mean, the most
pathological
important thing is for us to know that it's a neoadjuvant. So because it has to be processed this way. Otherwise, the standard is if you have a grossly tumor, lymph node, you just put one section because you know it's positive. So why bother? Correct. But for these ones, you bother because you want to know. I mean, imagine if that big lesion that had only a little bit of melanoma, everything else was fibrosis. Well, you will count it as no viable melanoma, or the other way around. So that's why for those cases that are larger, we need to know that it's neoadjuvant. And then in Anderson, I mean, we are very fortunate because the surgeons inform us, so we know that that's a especially processed specimen.
And how is that communicated? Meaning that is it on the pathology
And the
notes or
requisition. Actually, we have
Yeah,
one of them
yeah.
here, so.
You were one.
with no neoadjuvant at that point?
Yeah, I mean, it's a communication that's a key thing. The question I had was one that may not have an answer, but as we think about the continuum of the evolution of the regional metastasis, and we have a snapshot in time of an FNA or a core, and then we have neoadjuvant therapy, and then we have a comprehensive assessment, right, of what's there. But we don't necessarily have that comprehensive assessment up front. And so something that shows 90%, 50% necrosis and 40% hyalinized fibrosis, some melanosis, and let's say 5% viable tumor. We don't know that it wasn't already close to that, right? And that there was some effect. But so I wonder, have there been any studies looking at standard lymphadenectomies that would be processed in this fashion to see what we might learn about what the stochastics are of, the change from pre to, the on treatment biopsy? And also, are there differences are there patterns that emerge based on the size of the tumor, given some of the other competing risks of hypoxia in the tumor and things like that?
May I maybe
Please.
answer one part of that, Jeff? You just brought up a nice idea. S1801, the control arm is controlled for the same stage with no preoperative therapy. Maybe looking at that stochastic difference, how much of a non-neoadjuvantly treated lymph node is already undergoing necrosis, et cetera.
But they may not, would they have been processed? They wouldn't have been processed in the same way,
That's
right?
correct. They wouldn't have been processed necessarily section by section the same.
But I
That'd
can
be
tell you
easy to do,
our
right?
experience, it's actually very rare to see necrosis in melanoma. So fibrosis is not true because and we've discussed this in groin. It typically seen areas of fibrosis. Now it's suggested that it's because of the antigens coming from the genital and the GI regions, and then there is an immune response, and there's fibrosis. So fibrosis by itself, the hyaline fibrosis, that may be difficult to determine unless you have geographic, like the one of course, I showed the picture that looks nice, obviously. So the real cases, they may be difficult to, but then melanophages is very rare to see a necrosis in an untreated tumor. But it's, of course, I cannot tell you for sure how much of that is because the tumor was regressing on its own, because you can have a regression in a primary melanoma too. That's an excellent question. So.
Jim Heffley from Montana Cancer Consortium. In using immunotherapy with a variety of cancers, radiologically, we talk about pseudo-progression. And if we biopsy those areas, of course, we're trying to figure out, is it pseudo-progression or is it true progression? And what are the typical histologic findings of pseudo-progression?
Yeah. So the ones that we see as pseudo-progression, of course, I cannot tell you exactly what it was before, but then you notice that there were this area that had melanophages at the periphery. So what we think that is the pseudo-progression is the inflammatory response that you have there. That it looks like it's more active. If you're doing a PET, that lymph node, even though it had no viable tumor, you have so many macrophages that it's going to be active metabolically. So that would be an explanation of why you have. Now, fibrosis shouldn't be active. So if you're talking about PET, those should not be active areas, should be cold.
We will have about 30 of these cases in S1801 in the neoadjuvant arm that had radiographic progression. Maybe that's getting to a little bit what you're asking, where we will be able to say histopathologically what was happening.
And we are completely blind on those.
Yeah.
So before you ask.
Because a lot of times we talk about pseudoprogression and being fooled that it's really progression. Until you biopsy and then you get back
Correct.
inflammatory or, whatever, but it's.
Yeah.
Yeah, so it's difficult that we don't have any other true markers to try to figure that out.
It will be nice to be able to say, just for those listening in on Zoom, and the question was, when you see pseudo progression, you really don't know what's going on, how much of it is inflammation, et cetera. So it will be nice in these samples to actually be able to say, oh yeah, when it's progressing radiographically, it's also a lot of tumor progression. But if the opposite is true, if there's actually necrosis and then swelling happening due to apoptosis and so on, then that will be nice to see that too. Yeah.
Hello, Lilith Carpetian. So my question is about immune-related pathological response that actually, and referring back to the necrosis, where a nice paper from John Hopkins showed that there was actually not correlated with the radiological response and was not chosen to be one of the parameters of pathological response. So I'd like to get your thoughts about how do you think about assessing the immune-related pathological response, where there is a lot of emphasis actually to the T and lymphoid aggregates, plasma cells, rather than just the necrosis?
Oh, no, actually, that's a great answer. That's a great question. That's what I was mentioning, that even though this PCR, PNR only counts the percentages of the viable tumor, but there has to be something else. And because if the cells died, it's because something happened to them, whether it's CD8 or it's macrophages or it's something else. So that's what it needs to be done in addition to, and that's one of the things that we're looking at the microenvironment.
And when you speak about lymphocytic infiltrate, how do you think about that lymph node versus outside of lymph node? Do you have any criteria for that?
Sorry, the
For
question was?
lymphoid infiltrates, do you have any differentiating criteria how you think about it, evaluating inside of the lymph node or outside of lymph node?
If it is in a non-lymph node, that you can have lymphocytic aggregates. The first case I showed, that was a primary. So it still had lymphocytic aggregates, but not the lymph node. So remember I showed one case that I had very nice smooth border with the pink cell, sorry, the dark cells, those are the lymphocytes, but they had an area that didn't have the blue cells. That was an area of extracapsular extension, if that's what you're asking.
So the question is, do you still assess those within a lymph node tissue?
As part of the
Is it
math?
part of the evaluation?
Yeah, because we are looking at the amount of tissue. So if 100%, let's say that you have matted lymph nodes. By definition, if you have matted lymph nodes, the tumor cells just merge the lymph nodes, correct? So you have tumor that went from one lymph node to another through the fat that is there. So you don't care if it was one lymph node or not. What you're looking is at the entire tumor size. You follow me?
Right.
If you have a 10 centimeter mass in the axilla, that's not a 10 centimeter lymph node. With all likelihood is that there were several lymph nodes. They were just mushed together. So we count those as one entity, if you want to, because you're following me?
Right. I guess the point will be, do you think they have a similar meaningfulness when you assess them within a lymph node versus formation outside of lymph node tissue?
Well,
Since
we don't
that's
know
one
if
of
they
the
are the same or
criteria.
not, but that all the information that we have about survival, is based upon the tumor size. I'm not talking about now immunotherapy. I'm talking about 20, 30 years of experience. So if you have a metastasis, if it is a 1 centimeter metastasis versus a 10 centimeter metastasis, the prognosis is worse in the 10 centimeter, regardless if it was one lymph node or if it was 5 lymph nodes, if that's what you're asking. So when you get to that size, you don't know if it was one lymph node that was expanded or there were multiple lymph nodes that they were matted.
Thank you.
But This may be a question for surgeons. So do you treat differently if you know that it's matted lymph nodes versus if you think there is one lymph node that is 6 centimeters? It's going to be the same management, no? Because you go by size of the metastasis. Nope.
Great talk, Evan Hall, University of Washington, Fred Hutch. To echo some of the comments from some of the surgical colleagues earlier, I also treat kidney cancer. So I'm thinking about in a nephrectomy, we see necrosis with no treatment applied all the time. It's bad. If the path report reads a large percentage of necrosis, that's a negative indicator. And I just wonder if there is some way to look at, maybe it's not processed exactly the same way, but to look at the control arm of this study or a historic pre-neoadjuvant era of clinically positive lymphadenectomy specimens to say, what is the range of viable tumor cells in untreated melanoma lymph nodes to kind of refine our understanding of the pathologic effects of treatment?
Sure. And we will look at those that, of course, you can ask that, will this be representative of the entire lesion? But it's going to be a sample of the lesion, which is, after all, what we do in pathology. Everything we do is sampling. Because remember I told you that we put one every centimeter, but you are looking only at 5 microns. And if you look at another section, it will be 5 microns more. And if you look at 2 immunos, it will be 10 more microns. So out of a centimeter, you're looking only at, 20 microns. That's not a lot, but it still is enough to predict what is going to happen. It will be the same as breast wall thickness, correct? I mean, just imagine how silly, and pardon me, is to get a ruler and see how thick the melanoma is, and that's still the most powerful predictor. And that's in one section. So if you have a 1 centimeter melanoma and you look at the deepest area and you measure that, that's still more information than everything else that you can do in that one.
Representative.
Thank you.
Was it a question?
I'm not sure.
So just to get back to that other question, so I mean, the general theme that wouldn't be melanoma specific in the surgical oncologic dogma would be to be as minimally disruptive to the process as possible. So it wouldn't be to tease out to identify intraoperatively if it were matted nodes or separate nodes. It would be to be resecting en bloc with or anatomically defined by the landmarks for a dissection. Regarding the pathological processing and not being a pathologist, it's fun to ask these questions to one of my closest pathology colleagues is for many pathological interpretations, the goal is to identify viable tumor for diagnostic purposes, but here, and so I'd imagine that would be a tenet that would be carried forward if there was no other disruption of that normal workflow. So would it be more likely in a patient processing when not in a more structured, geospatially mapped approach for a neoadjuvant specimen to actually be lured towards the viable tumor rather than sampling necrosis because you're already sort of visualizing that as you're doing the grossing?
That's a great question. In general, in pathology, what we try to avoid is the necrotic areas. Because of course, if it is necrotic, you don't get much information. But in melanoma, unfortunately or fortunately, the necrotic areas are pigmented. So the person who's grossing the specimen is drawn to those because you see a lot of pigment. So I think that for those cases, it will be more likely to find the necrotic areas than to find the viable areas. But there should be, we're going to come up with the recommendation, correct? So I think it should be, if you have a lymph node that is grossly positive, you should have at least 1 section per centimeter from now on. I'm not talking about more,
It's a question about the long-term benefit of the PET-CR or the PR in immune therapies is quite clear, I think, at this point. But if you have PET-CR on target therapy, and you guys have a lot of experience with neoadjuvant therapy of target therapy and immune therapy, but it seems to me that PET-CR in the target therapy may not be as durable as immune therapy. So even if you see very small percentage of the viable tumors in the target therapies, if they progress within 6 months, then what's the another predictive factor? Is it a lymphocyte presence that predicts the longer term the benefit because of immunotherapy, or what else can be the second factors predicting their long-term benefit aside from the viable tumors?
Well, I mean, that's a question difficult to answer, but as you mentioned, there seems to be the two groups, correct? If you're talking about targeted therapy and immunotherapy, in the way I see it is that targeted therapy is trying to kill roaches, correct? So you kill the roaches, but then you have 10% of the roaches that are immune to that poison that you, so when the 90% die, the ones that are immune to it, they come up. Versus if you're doing immunotherapy, which since you are targeting the antigens, it's actually your immune system that is attacking them. So I think that that may be one answer, and then I don't have the data to support it. But why you have long-term, so if you look at the original curves from vimurafenib versus ipi/nivo, so it was a higher response rate, but then 6 months later, the tumor came with a vengeance because versus the immunotherapy, in which those patients, the curve tends to be more horizontal. And then I think that that's the main reason, that because the ways of attacking the tumor cells are different. Now, I don't think we have the data to prove that if you have more lymphocytes, it's going to be longer survival, but maybe we're going to be able to see it now in this and other studies.
Victor, would you allow me a couple of questions?
Please.
More? So evaluation of the tumor bed. I've heard Richard Scollier describe it, and I honestly just don't remember his answer. When you have a post-operative, post-neoadjuvant specimen, how can you be sure where the tumor bed originated?
That's a great question. Let me answer with a facetious answer. I asked once a very famous pathologist, how do you know that it's osteoid and not fibrosis? And this is a crucial, if you are not familiar with soft tissue tumors, osteoid means osteosarcoma. So if you have a malignant tumor that has osteosarcoma, if it has fibrosis, it's something else. So his answer was, because I say so. And so, I mean, I wouldn't say that this is the same, but what we interpret as a tumor bed, it's a combination in which you see some fibrosis, some viable tumor cells, some necrosis, and some melanophages. And typically is what I showed. So you have an area that is well defined. It's not like you have a few melanophages, a few necrotic melanocytes, a few fibrotic areas. You know,
Yeah.
It looks like a geographic,
Yeah.
which of course it may be just a selection, a bias selection. So unless you see that, you don't call it tumor bed. You know what I mean?
Right. I guess that's my concern, is I wonder if a pathologist might say, oh, I'm just calling the area that had the melanoma the tumor bed. And then the percentage of viable tumor is more of that denominator than if he realized, oh gosh, it's this
Yes.
whole specimen. Similar to that, when you have multiple lymph nodes removed, you just showed, and I guess we don't know how frequent this happens, but you showed disparate effects in different lymph nodes.
Correct.
So then, are we adding those denominators, those tumor bed regions together for the entire denominator to calculate percent viable tumor? Or is each lymph node its own control? This lymph node's denominator is what it is, and it's a complete pathologic response. And then this lymph node is major, added together, it would be major. I don't know what the answer is.
But that's what we're doing the study.
Yeah.
Right? And Jeff is going to remember this, but now it's 20 years ago. We look at the metastases, micrometastases in sentinel lymph nodes of melanoma. And a painstakingly study, we counted every single metastasis to every single positive lymph node. And I'm not talking about the metastasis, I'm talking about every cluster.
Mm.
And we were lucky because we realized, if you remember, that the largest of the tumor deposits had the same information, prognostic information, as measuring all of them. So
Mm.
I hope that's going to happen the same with this,
Yeah.
because otherwise it's going to be really painful
So
having
perhaps
to measure every single
each
one. you know?
one. So perhaps what's happening in the most responsive lymph node or the least responsive, we just don't know. So my last sort of basic question, I guess I have two basic questions. You had said a couple of times, gross examination is very important when you're reading these. Is that gross examination by the surgeon, the surgical technician, the grossing technician, or the pathologist reading it?
Well, the surgeon hopefully is not going to be cutting the tissue,
Okay,
because
sure,
otherwise it's going
fair.
to be difficult. So if you're looking only from outside, what it will be helpful, and then I would like to confirm from the surgeons here, will be if it is matted lymph nodes or not.
Yeah.
And that's important for the count.
Yeah.
Because some of the protocols, as you know, they require a finite number of lymph nodes. In the groin, it has to be 15 lymph nodes. In the neck, has to be 15 lymph nodes. Otherwise, there is not enough. But if you have 10 of those lymph nodes that are matted, obviously you're not going to get to 15. So that will be important for the count. So that would be one. And then the person who is actually cutting the tissue, it will be the technician. Whether it's a pathology assistant, a resident, a fellow, or a pathologist. It can be any of those four.
And
That's what is important.
do you think this neoadjuvant era leads to some re-education for that group of professionals because they have to, their grossing is playing a key part of how they section this one. And okay, my last one, and then I'll let the microphone go. How much of this math that you do, percent viable necrosis, fibrosis, and et cetera, melanosis, how much of that can be done on an H&E alone? How much of that actually then needs further staining?
The majority will be on H&E.
Okay.
Now, I thought you were going to ask me how much of that can be done digitally.
Oh, well, that's a great follow-up
Because-
question.
Because, I mean, let's face it, if I examine the case and I say, oh yeah, there's 30% necrosis, it's eyeballing. Now, it may not be important 30 versus 31 versus 29, but if it gets to a point that is really important,
Yeah.
we will have to do that digitally. And if you look at neuroendocrine tumors of the GI tract, 20% is the magic number. If you have 21%, it's really bad. If you have 19, it's relatively good. Really?
So pathologists are really good at guessing jelly beans in a jar. I would think
Yes.
you win those.
Well, at
contests
least
all
we
the time.
hope we are good.
Do you
But
really
it's-
believe that?
Yeah. That's why I said we think. No, but definitely, if we get to a point that what I was saying about the 90%, if 90% is the magic number, it will have to be done in a more scientific way than simply looking at it. Now, the next thing you're going to ask me, well, does it really matter if you are only looking at a sample
Right.
of the sampling of the lymph node?
Right.
Well, we don't know, but if it is true, we will do it. You know what I mean? It's the same as at the Breslow thickness. Breslow thickness is really, really crude way of examining the volume of the tumor, but it works. So if we are going to do something and it works, we will do it.
I had a question.
Please.
I always wondered, and you'll just have to educate me here. When we decide something needs to be done clinically, we do it in a trial and there's a hazard ratio. For these things that are pathologic, what is the statistical criteria to sway you one way or the other? Like, how much do you need to make a decision to say, oh, it's really this way, 21 versus 20?
Well, because what you do is you don't know the follow-up. That's the way we examine this. We are blinded. So as Samna said, there will be cases that weren't even treated. So I have no idea which ones those are. Now, after you look at those, you throw the numbers basically, and then you say, okay, what 20%, 90%, 50%, maybe it's a combination. Maybe it's not how much viable tumor there is, but rather how much inflammatory response there is, because that inflammatory response maybe still kill the other melanoma cells that are somewhere else.
I guess another way to ask this is, on a trial, we power for clinical events. Are you powered to answer some of these questions you're asking? Because it's so dependent on what's happening. So how many events do you need to say, okay, I feel confident that, if it's more than 20, it's going to be bad. Do you see what I'm saying?
Because
we've designed it this way. So yeah.
But remember, the endpoint is not the amount of necrosis.
Okay.
The endpoint is clinical. So it's response or not.
Right.
It's only that we're trying to see, okay, if we examine the lymph nodes this way, can we predict which patients are going to have a good response?
Theoretically, what we'll do is we'll determine the path response and the, whatever percent viable or percent necrosis on each specimen, and then their EFS date, their EFS number, and maybe be able to form some nomogram where you can cut it and say, above or below this is where the difference is, but.
And we have here one of the world experts with the
Yeah.
AJCC, because that's basically how the AJCC classification is done, correct? You're looking at the criteria and you see how well they predict
Clinical.
behavior, and then you keep modifying and modifying.
Yeah, so so for the neoadjuvant pathological processing, the categories have been identified a priori in a way for complete, near complete, right, partial and non. And so, and then it's the data that it will drive whether you could be a clumper or not, and where that threshold, if it's dichotomous, might be, where we've already seen differences between targeted and, immunotherapy in that arena. I had two quick questions to follow up on Sapna, because she was asking my questions as I was online here, but that's okay because you're the chair. One is related to the digital pathology and sort of by extension inter-observer variability, where in other aspects in primary tumors, you and other colleagues have been involved in sort of shaping the international landscape on looking at inter-observer variability for Breslow thickness, for thin primaries, for ulceration, for mitotic rate. Do we need to do that now too, if decisions will be made based on a few percentage point differences, right? Is there an opportunity to do that? And can a cooperative group ever consider sort of that kind of assessment that would have immediate, potential clinical impact? And then related to the question of how do you sample? Pick, let's say, 3 vignettes. Let's say that in an axillary lymph node dissection, prior to neoadjuvant therapy in an index patient, someone had 10 out of 25 lymph nodes, another person had 1 out of 25 lymph nodes, and then someone else had some big mat of nodes and hard to distinguish. In terms of that sort of model patient now being subjected to neoadjuvant therapy, in terms of adding things up, if the sort of the pretest probability or the actual data was that only 1 out of 20 some odd nodes was ever tumor involved versus 10 were tumor involved, how does the math work? And there could be huge implications if only an index node or nodes was then assessed. And maybe that's what you're also driving at. I don't know the answers to any of those, but those are things that we'll probably need to consider going forward.
Yeah. So the first question, the answer is yes and yes. Yes, we should do this. The question is why we are not doing it yet. And we are not doing it yet because not all the slides are scanned. And we have to determine how we are going to measure it, because we don't even know if you're using the AI to look at those, and if you're looking only at pigment. Remember I showed that melanoma that was heavily pigmented next to the macrophages. It's going to be very difficult for AI unless you teach that particular tumor, these are the macrophages and these are the melanoma cells, even though they look similar. So, but yes, we're going to need to do that because it's, as I said, the 20 versus 21 versus 19, that's not going to work. And I know myself, if I looking at what the jelly bean, not in the jar. So today they look like they're 150. And then if I look at it next month, it's going to be 162. And then a year later, it's going to be 148. And it's because we are guessing. We are not counting. My dad was a clinical pathologist and he had to count the red cells, the neutrophils, the basophils, and with a grid. I mean, I don't know if you're familiar with it, because before machines were, you had to look at it with a microscope. There was a reticule, and then if you've done a statistical analysis, the number of events touching the reticule, you multiply, and you can quantify. And that was really more precise than 10% or 21%. But so yes, digital. And then you were asking the second question about how to predict
a priority number of nodes that are involved and how that impacts on
Well, that's a very good point, because we know that if you have 10 lymph nodes, that's AJCC stage is higher than if he has only 1 lymph node, correct? Because it will be a 3C versus.
The difference here is that the denominator would be the total number
Yeah.
of nodes, not the C.
But what I'm saying is that that's true in untreated patients. But if you are treated and the 10 lymph nodes are completely gone, is it the same as having 1 lymph node that is completely gone? That we don't have the answer. That's something that we have to look at. But it's probably, I would say it's if you have 10 lymph nodes and all 100% dead, should be the same as if you have one lymph node that's 100% dead.
Or if you have 10 lymph nodes and only one was involved and they're all the same size, is it a 90% response if the one node that, like, how do you do that now?
So hopefully we'll be able to have an answer. I mean, it's not going to be 100% of the answer because otherwise we are not going to have anything to discuss about next year.
Yeah.
But it's yes, but then probably we're going to get closer to it.
Well, everyone join me in thanking Dr. Prieto. That was such a great discussion. Thank you. Okay, let me bring the speaker book up here. Josh Mammon, I think you're up. We're going to move on to our active studies discussion. And we'll hear from Josh and then from Zainab. Okay, let me find my mouse. It's a little hard to see the mouse on this thing. Let me pull it down to the bottom so I can just see it. There we go. I am. I can't see it. Okay, I'm somewhere over there. You can't see the mouse, you guys. Is it on your extended screen? Do I need to like keep swinging? It's there somewhere.
Which one is it?
It's number 2. Oh, there it is. Okay, thank you. Let me go here. Window 2. Good, yeah, thank you.
All right, well, I get to speak a little bit about 2015, which many of you also call MELMART because that's what it's known as internationally. So just a brief review about S2015. I know that most of us here have heard about this for the last several years, but just a reminder on why this trial is relevant. This is a margin trial trying to standardize what the appropriate margins are for primary melanomas that are T2B or greater. Kind of the rationale for this trial is, though there have been numerous randomized trials evaluating appropriate margins, there's still heterogeneity on what's done internationally. And additionally, you know, there's some thought that maybe we don't have to do as big of margins as we have been previously. So the primary endpoint for this study is disease-free survival, but it also looks at other endpoints, including local recurrence, overall survival, and melanoma-specific survival. Just to remind everyone, a very simple schema. So these are T2B melanomas. There are some exclusion criteria that are relevant, like can't have microsatellite mitosis, for example. Individuals are stratified based on AJCC stage, age, country, which is relevant nowadays because of adjuvant therapies that are approved in some countries and not in others, and gender. And again, very simple randomization of 1 centimeter versus a 2 centimeter margin. All individuals are required to undergo a sentinel lymph node biopsy per standard of care, and then followed up for up to a minimum of 5 years, and then in some cases up to 10 years. This is often questions that's asked is, are we participating right now in the quality of life PRO component and specimens? And the answer is no currently, though that might change. Hopefully it'll change by the time we have our next meeting, so stay tuned. This is the current status. So it activated pretty much at the last spring meeting. So it's been about a year, which is kind of exciting because it was great news last year. We have more than 70 sites now open. So thank you all who have opened the trial, and 166 subjects. Our SWOG accrual goal is 880. I'm estimating right now that we're accruing about somewhere around 15 new subjects per month. And I expect that to continue to accelerate. So I think we'll be well on our way. These are the top sites for SWOG accrual. Thank you. So thank you if you're one of these sites, and even if you're not, thank you, because I think we're doing a phenomenal job in just a year. And also our partners from the other cooperative groups, Alliance, SWOG, and NRG Oncology, which have all continued to contribute substantially as well. This is, I think, a really exciting curve, and I won't go into any of the specific details, but the top line, that green line, is what accrual had been hoped for initially internationally. And of course, the pandemic did affect that slightly. But the lower line or the blue line is where we are now. And the yellow line leading from that kind of blue line is what's anticipated to do over time as new institutions come on board. And as you can see there, it's possible that the trial may even close earlier than anticipated, which is really kind of exciting and I don't want to say unprecedented, but unusual for a clinical trial. This is just the accrual according to country. I always like to point this out because the United States is the top accruing country, and I expect that will continue to remain that way. It's not a competition, as I always say, but I'm happy about this, certainly. And these are acknowledgements, and I thank everyone from SWOG, of course, from MASC, which is the Australia and New Zealand group, CTEP, and then, of course, our patients who bravely are willing to be randomized on this trial. Thank you. I'm happy to answer questions. All right, thanks.
Okay, next we will hear from Zeynep Erolu, who has S2000 as an active study. Let me find the slides here. And if I could entice those of you here to maybe stay to the end of the meeting, we will, if you're new to SWOG, if this is your first cooperative group or SWOG meeting, we'll do an introduction where people can just say who they are, where they're from, so we can get to know everybody. And then we have a special save the date we want to let you know about.
Thank you. So I just wanted to give a quick update on S2000. So for those of you who don't remember, this is our randomized phase 2 study looking at encorafenib and binimetinib with nivo versus ipi-nivo in patients with melanoma brain mets. So the major update since the fall meeting has been the amendment, which is now active and was approved through CTEP, where essentially we're focusing on patients who have symptomatic brain mets, whereas previously the study permitted both asymptomatic and symptomatic. Reason for this is some of the data that was published from the Tricatel study last year, which was another triplet, Vemcobi-Atezo, single arms phase 2 study that had a cohort for symptomatic brain mets and actually had a 6-month PFS of 57%, median PFS of 7.2 months in first-line treatment in melanoma brain mets, symptomatic patients. And we know that with ipi-nivo in the same cohort from a separate study, the 6-month PFS was only 19%, median of only 1.2 months for PFS. So essentially, this allowed us to redesign the study to a much smaller sample size, as you can see here. So this is the current schema, essentially the only difference being that the study is only for symptomatic patients now, and the sample size is down to 28, 14 patients per arm. Still stratifying based on, more 6 months or less or more from prior neoadjuvant or adjuvant treatment. And the objectives remaining the same, looking at progression-free survival, so global PFS, and then same secondary objectives of survival, response rates, toxicity. The eligibility, again, only changes symptomatic patients only, allowing up to 8 milligrams of dexamethasone a day for steroids. Again, prior local regional therapy, radiation, or surgery is permitted for brain mets as long as we have one measurable progressing brain met at least 5 millimeters in size. Leptomeningeal disease is also allowed. Patients don't need extracranial disease, and neoadjuvant or adjuvant immunotherapy or targeted therapy is permitted. So in terms of the current enrollment status, so again, with the redesign, we need 28 symptomatic brain met patients. So the current stats we're looking for, it was designed based on 80% power to detect a hazard ratio of 0.41. So again, felt we could be more aggressive because we're looking at symptomatic patients with the triplet versus ipi-nivo. So we need 24 eligible patients, 28 total. Currently of the patients enrolled, we have 20 thus far with symptomatic brain mets. So we are on our way to hopefully finishing the study within the next year. So we have 20 of the 28 needed, and we will still go ahead with analyzing the data from the asymptomatic patients that were enrolled prior to the amendment becoming active as well. And that's it. Any questions? Oh, okay, thank you.
Okay, we'll move on to closed studies. The first one that we'll hear from is Carrie Kendra for S1512. There's no slides for this one. It's just a verbal update. So we'll hear how that study's progressed.
No slides, short presentation. For S1512, the study has met accrual, and we presented the data from the unresectable cohort at a plenary session at AACR. And the manuscript is in preparation. That's it.
When I wasn't sure, did you have any updates? Would you like to give a verbal update on 1607? I think you did send them to me, didn't you? I'm sorry. Yep, you sent them. I'm sorry. Here we go.
So we presented the clinical data and some translational data of 1607 at ACR 2023. And I'm going to just briefly go through it because this is really the first time when we talk about this in this group. So as you all know, this is TVAC plus anti-PD-1 plus pembro in melanoma patients who have already progressed on anti-PD-1. And just to remind everybody, what we're trying to accomplish is to try to reverse the T-cell exclusion associated with melanoma that does not respond to anti-PD-1 by using this intratumoral injection of oncolytic virus. So there are two cohorts. Cohort A, the patient don't have visceral disease, and cohort B, patient do have visceral lesions. And then we think the biology is different, so we want to separate them. And this is just briefly the eligibility criteria. Everybody has to have a prior progression on anti-PD-1. Our primary objective is objective response rate. So here is the results. So we recruited 11 patients to cohort A, and it was closed early because there was no, after 11 patients were recruited at the interim analysis, we don't see any confirmed response. There was one unconfirmed response, but then the patient later progressed. So that cohort was closed. Remember, that's the cohort that has visceral disease. And for cohort B, for the patient who don't have visceral disease, it passed the interim analysis criteria. So we actually recruited 27 patients into that cohort. And there are 7 confirmed responders, 2 complete response, 5 partial responder, and the response rate was, objective response rate was 26%, and they rejected the null hypothesis of 10%. So it's actually a positive result. And the treatment was very well tolerated. And then on the bottom, it's just 2 cases. On the left is a patient my colleague Dr. Hingzhum treated. The patient had multiple lesions growing after anti-PD-1 therapy, and you can see all of them responded. And then on the right side is a patient Dr. Ribas treated. Is a huge tumor, and after 2 months, the tumor was it disappeared. So, and these are just demographics. On the left, you can see, between the visceral cohort and non-visceral cohort, the demographics are very similar, and it's really consistent with what we see in this patient population. One of the difference, interestingly, is the gender between these 2 groups. So in the patient who have visceral disease, 2/3 are male, And in the patient who actually don't have visceral disease, 2/3 are females. So I don't know what's the significance of that, but that's something different between these two groups. Others are very similar. And on the right side is really the result table. It's just it's a breakdown of different lesions, injected lesions. Actually on the top is the entire cohort, and you can see on the right side is cohort B, non-visceral cohort is 26% of response rate. And then, it's breakdown into injected lesions, non-injected lesions, and obviously the patient who, the lesions that is injected has higher response rate. Also, we actually get the information about whether this is acquired resistance or primary resistance. So the definition is the patient who had prior anti-PD-1 and never had a response is primary resistance. And then if they had a response and later on progresses acquired resistance. And as you can imagine, there are much less acquired resistance, but interestingly, the two patients who had acquired resistance and then come and got the combination in cohort B, both of them are responders and have really good survival. So this is just a progression-free survival and overall survival results from these patients. And as you can see, it's a pretty durable response. Remember, these are patients who have already progressed on anti-PD-1. And on the right side, it just shows in cohort B, the two patients that had acquired resistance, they had 100% survival even after 3 years. So this is the durability of the response is very durable. So, and then, we actually had paired biopsy of all the patients recruited to this trial. So we have a baseline biopsy and then on-treatment biopsy. For on-treatment biopsy, there's, we biopsy injected and then non-injected tumors. And all the samples were shipped to UCLA, and Katie Campbell, who actually presented this data, earlier today in the working group. Oh, she's right there. I don't know whether she wanted to come here and present it. She actually did this analysis. Katie, look at the CD8 staining of these samples and correlate that with a response. And as you can see in cohort A, there's not much difference, between because we don't really have a responder there, but stable disease, progression of disease, the CD8 infiltration is very similar between, injected and non-injected tumors and at baseline and on treatment. But if you look at the right side of that figure on top, in cohort B, these are, patient with no visceral disease. You can see the patient who had in the response there is a massive amount of CD8 infiltration in general compared to their baseline. So the TVAC injection really increased the T cell infiltration consistent with our hypothesis for the patient who benefit from this combination. And then the figure at the bottom is, a breakdown, just for individual patient, if you look at the trend, of the CD8 infiltration, you can see on the left, the patient who have a response had increased CD8 infiltration after injection. And we also wanted to look at whether, the response is related to tumor mutational burden, but there's no difference between the responders and the non-responders, in terms of overall tumor mutational burden. And then there was some, Katie did some very detailed analysis of different mutations and look at whether there's any difference between responder and non-responder. There's actually not much difference here. What is reassuring is she also look at the TVAC infiltration or, TVAC expression in these injected tumors. And we only, in all of the tumors, and the TVAC integration is only found in tumors that's injected. So that's reassuring. So our conclusion is this combination TVAC plus pembro is in melanoma patients who have progressed on prior anti-PD-1. It does have efficacy in the patients, in the subset of patients who don't have visceral disease. And this combination can actually is associated with durable response and significantly increase the CD8 infiltration in both the injected and non-injected tumors. And also the response to this combination occurred in both primary and acquired resistant tumors. So there are additional translational study that's ongoing. We're looking at a specific subpopulation of cells in the tumor microenvironment and see whether a special population is associated with a response or resistance. So that's the end of it.
Sorry, I was just curious whether at some point you'll have enough tissue and enough money and enough time to look at, I don't know how granular you'll be able to get in terms of T cell receptor antigen specificities, or at least families in the injected versus the uninjected, because now you've proven that the
Yep.
TVEC virus is not expressed in non-injected lesions as the improved concept. But what you'd like to see, I guess, is the immune ability to go to those
Right.
other sites and display the same antigen specificity, right?
Yeah, that's a good point, Kim. And it's actually, I didn't show the initial translational plan. It's actually one of the plan. And, Kitty is looking into that. She's actually looking at, the whole exome sequencing data, RNA-seq data, and we'll have much more granular data soon.
Yeah, so the one thing I will clarify with the TVEC detection, it was from the whole exome sequencing, since the modified herpes simplex virus TVEC is a double-stranded DNA virus. So we focused on getting that information from the whole exome sequencing. And we're working on thinking about how to include this analysis from the RNA sequencing. But we are also thinking about how we can use the density of the data, the bulk RNA and the bulk DNA, to look for T cell clones, look for consistencies across those, as well as mining some public databases for viral associated responses to consider that as part of that equation.
Thank you, Katie. All right.
Okay, I'm looking at Ari Vanderwald, but thinking I should be looking this direction for S1616.
Hi, everybody. These are Katie's slides. I'm Ari Vanderwald. I don't know why I'm up here. So 1616, for those of you who don't remember, is a study that is looking in patients who have failed PD-1 therapy. That's not fair. If Tony's on the line, he's going to be really upset with me for saying that. Patients for whom therapy has failed, and PD-1 patients, and I apologize for saying it incorrectly. And looking at whether or not doing combination therapy with nivolumab plus ipilimumab versus ipilimumab alone is going to be better for those patients. The study completed accrual in 2020. We randomized 94 subjects in 34 different sites in many different states. This was a real amazing achievement for this number of patients across various different SWOG sites, especially considering the number of biopsies that we were able to get. And Katie will talk about that in a moment. And then this was the primary endpoint that we presented last year at AACR to a room that was absolutely full in the plenary session of AACR. There were about 2,000 seats and about 20 people. For those of you who were there, you're one in a million. The median PFS is irrelevant, and I don't know why we put it on this slide, but the hazard ratio was 0.63 in favor of the combination arm. 6-month estimates showed that there was 34% patients that had not progressed on the nivo-ipi arm at 6 months versus only 13% of patients on the ipilimumab arm. The objective response rate was 29% in the ipilimumab arm in the nivo-ipi arm and 9% in the ipilimumab alone arm. So this had a p-value of 0.04, well 0.037 in case you want to be really exact about it. And the paper is currently under review in Nature Medicine. And Katie will now talk about some more interesting things.
I think he does a much better job at introducing the clinical background of it. So this will be a little redundant for the people that were at the working group this morning, but I just wanted to kind of give you a flavor of the density of translational work that we're doing with this trial. I will emphasize that this is standardized sample processing that we've implemented across several studies, including 1616, 1607, as well as the 1512 cohort. This really complicated slide just gives an overview of that entire workflow, but at a high level, we're trying to for as many biopsies as possible. And out of the 92 patients, we have samples from 86 of them, including 274 biopsies. We're trying to perform bulk whole exome and RNA sequencing, and then histopathologic analysis, and then multiplex spatial profiling using various modalities across the different trials. And we're using that from sequential cuts so that we can also go back and start to think about how we can integrate these types of data. So at a high level, the genetic subtypes are kind of shown here, where we see patients with BRAF activating mutations, NRAS hotspot mutations, as well as a few NF1 loss of function, but less so. There was no statistical association with any particularly recurrently mutated gene in terms of with respect to response or resistance. But we did find there was a patient with homozygous loss in JAK1 that did not respond to combination therapy, and a patient with a homozygous loss of beta-2 microglobulin. And so we're taking a particular focus of some of these patients to consider how these mechanisms may be relevant in the primary resistance setting. So what I'm excited to share today is some of the results that we've been doing, or some of the results from the multiplex spatial profiling to consider the immune microenvironment and how that changes over the course of therapy. So in order to perform this was a collaboration with the Parker Institute for Cancer Immunotherapy and working directly with IonPath for sample processing. We selected 27 patients, including responders to combination, non-responders to combination, and non-responders to ipilimumab monotherapy, collecting screening and on-therapy specimens. And then from the slides, in addition to the bulk sequencing and histopathologic annotations, that we could select 800 by 800 micron fields of view across all of the specimens. We were able to appreciate 220 regions of interest across these 43 samples. So when we start to put all of this together to explore the different cell types that are present, we can start to look at all of them in parallel. I find that these plots, while informative, are a little bit hard to look at given the number of colors and the number of patient-specific changes that may be happening. But the one consistency that we did see when we looked at paired specimens, there was not necessarily an outlier feature at baseline or on therapy, but the thing that we started to notice in these combination responders is that there was a decrease in the amount of tumor cells, as well as with a concordant increase in the number or percentage of CD8 and CD4 T cells even, which is consistent with what we know mechanistically about anti-CTLA-4 and anti-PD-1. So in order to think about what these CD8 T cells are doing, and this is a bit of work in progress, but kind of a flavor of all of the analyses to come, we investigated where and what these CD8 T cells may be doing. And so performing unsupervised clustering, providing features associated with the expression of the markers, as well as the percentage of other cell types within 30 microns. We were able to identify 13 clusters. And because of this approach, we can also say, what are the features associated with each of these clusters? Identifying cluster 0 in the second column. I apologize for the smallness of the fonts, but what I can share is that cluster 0 highlights the expression of Ki67 for proliferation, exhaustion markers such as PD-1, LAG3,
TIM3, as well as potential activation or effector memory with response to antigen engagement of granzyme B and CD45 row. And most importantly, given the questions that we're asking about where the CD8 T cells are, is the fact that these CD8 T cells are close to tumor cells, which gives us some indication that they may be tumor associated. Given the nature of imaging data, we can even go back and look at these things. And here I show three of the same screenshots, but with different markers. And so each of these circles is an individual cell segment that we identified. The dark blue is its nucleus. SWOG10 indicates the presence of a tumor cell, which is outlined in orange, such as here. And then here we see the Ki67 expression in the nucleus. And the fact that this is really white or bright white in this cluster 0 CD8 T cell indicates that you have overlapped expression of the immune synapse proteins and those co-receptors to the active T cell receptor, giving us some indication and some sort of actual photo of these CD8 T cells engaging with tumor cell targets. And so we're trying to explore this further, as well as consider the other cell types that are involved and think about the orthogonal validation that we can perform across the various data types. There haven't been any clear genetic mechanisms at the cohort level. Given the statistics and multiple hypothesis correction, this can be very challenging. But we are taking a targeted look, and Natalie in the crowd is also exploring the spatial transcriptomics and other technologies we can think about to explore some of these mechanisms. And I think it's really important to consider the integrated analysis that we can utilize moving forward. And I think it helps us inform which pieces of data are the most supportive to understand how these drugs are working as well. And then my favorite slide of all, acknowledging all of you and the entire SWOG network, because without the patients and the people running these trials and seeing these patients, this would not be possible. But also my incredible boss and leader, Tony Rivas, and the entire team we have together. So happy to take any questions.
Thanks for a great presentation, David Lawson from Emory. Did you see any role?
Could you try to go into the microphone so Zoom can hear you?
Okay. Did you see any role for B cells at all in this response?
So thus far, we have not seen too many B cells hanging out. We do see a few lymphoid aggregates, but we don't see too many B cells kind of on their own. This is something we're considering. The other thing I will propose with regards to the 1616 trial is the correlate of TLSs and the association with response kind of excludes that, given that these are PD-1 refractory melanoma tumor biopsies. And so just by the nature of the cohort, I don't anticipate seeing as many lymphoid aggregates, but we do see a few. We especially see them in a couple of the lymph node biopsies. So,
Right. Thank you.
Mhm.
Nice slides and nice pictures. The fact that you only saw the JAK mutation in like 2 patients out of like a certain denominator, doesn't that suggest that that's not a particularly like a common resistance mechanism, I guess? You would expect to see that more often, right? And also, do you see more CD8 cells in the combination arm compared, or is there some particular like situation where you see more CD8 T cell? I mean, I feel like we already know that, right? Like that response rate. I mean, or is the point to just recapitulate that in the refractory setting?
So I'll comment on the first part. You're absolutely right. So in terms of the patients where the JAK1, JAK2, B2M mutations were discovered was in the acquired resistance setting. And that's a really important point as we think about the mechanisms of primary resistance versus acquired resistance, because acquired is associated with the selective pressures due to the immunotherapy, whereas that primary resistance is in the upfront. And those aren't entirely overlapping, and it is very hairy across tumor types, as we've seen in colorectal mismatch repair and these other, and lung cancer, where we see different patterns of these known mechanisms of immunotherapy therapeutic resistance. But I think we're starting to get to a point where we have to think about what's in the primary resistance versus the acquired resistance. And the answer is that these are rare events. We usually see a handful, maybe like 1 or 2 patients in each cohort in the primary setting that these are implicated. Some of the preliminary work that we're seeing suggests an additional look at the clonality of some of these events, where when it comes to copy number from bulk whole exome sequencing, unless you have multiple samples, you're not really going to get a good sense of what a subclonal copy number alteration is going to look like. So this is where we have to start thinking about what modalities might start to highlight that a subclone might have this resistance mechanism, but the whole tumor might not. And so we're thinking about that in parallel. As for the second part, I agree. Nothing I said was unobvious in terms of, the known mechanism of certain things. I think we have a few opportunities here to refine some of the way that we annotate these features. Given the advances in these technologies, we can also think about what data types are orthogonally validating them. But given the nature of the MIBI panel, which has 32 proteins and the resolution of 0.25 microns, we can start looking at these direct cell-cell interactions and the cell states associated with them. So I think that we're just at this kind of the first page of this entire encyclopedia of information. And so I think moving forward, I think it's good to start with these questions that we have a good understanding of, rather than going in with this entirely unsupervised approach, because we're working with 17 different cell types and potentially an infinite number of cell states. And so I think, I don't think I presented anything novel mechanistically.
For the Visium, I mean, that data looks really cool, but can you tell that those are clonal based on some, like, will Visium let you know based on your TCR, like repeats, or I know with, if you do single cell sequencing, you can tell if they're clonal or not, because, you just see the same TCR show up again and again, but does Visium let you do that? And also, if you look at the Tregs, can you tell if they're clonal either, or not really?
So this is where we have to think about which parallel pieces of information we have going on. And Natalie can correct me if I'm wrong, but we're working with FFPE tissue. And so all of those methods are going to be probe-based, which is usually not going to give you the TCR clones, but you can at least start to validate things about the tumor clonality if there is variant detection from those probe-based areas. The TCRs, you're absolutely right. With our data type and with the type of data we have right now, we can't necessarily say that these are clonal T cell populations. Moving forward, we can consider the validation steps associated with RNA scope if we have a TCR clone of interest. So there's a couple of things that we can think about moving forward. For now, we're focused on this clarification of the microenvironment.
So Visium won't tell you if it's clonal in that cell? I see.
Yeah, so the answer for everyone is if you have fresh or frozen tissue OCT preserved, then you'll be able to use full length sequencing reads. And that's what you need in order to pick up a TCR clone. But in terms of FFPE, you're going to rely on probe-based technologies because a lot of those molecules are degraded. And so unless you go in with probes for your TCR of interest, then no, you won't get that information from that data.
I see. So, and can you tell if the Tregs are clearly associated with lack of response? I mean, can you say that much, or is that even hard to say?
The percentage of what's really nice about Tregs is that the marker we use being FOXP3, the fact that it's nuclear makes us feel more confident about calling those cell types. With imaging data, how do you say that this blob starts and this blob ends to say that that's the division between those two cells? So having nuclear markers like FOXP3 is really helpful. We have not seen a direct pattern. They seem to be much rarer in the tissues that we're looking at in our data set.
Okay, I'll give the next couple of updates just verbally here on S1801. That study, as you know, we were looking at pathologic response as the next kind of major presentation or outcome to look at. As New England Journal of Medicine kept telling us, it's pathological response, but that feels sinister to call it that. It's pathologic response. So that'll be the next bit of work that Dr. Prieto is doing, and it's underway as we speak. For S1404, we have had a publication since the last meeting that we got together. We published the quality of life data. It's in JAMA Oncology, the February 2023 edition. Adjuvant pembrolizumab improves quality of life outcomes compared to high-dose interferon or ipilimumab in patients with resected melanoma. And that's by Dr. Unger and our S1404 team. So I'll pass it on to David Lawson, followed by Kevin Kim, who will give us a couple of updates from the ECOG Akron Melanoma Committee.
I want to thank you all for the opportunity to come to San Francisco. It's a beautiful city, always has been. I want to thank that gal for this slide, which is going over our SWOG ECOG trial portfolio. We've already heard from Melmart and as our open trials, and then the EA 6194 neoadjuvant Pembro trial is not one that SWOG's been particularly interested in, but that's Pembro plus a toll-like receptor agonist. It's accrued 28 out of 60 patients. It's expected to close in 3/19/24. It's headed by Dr. Tarhini, who is a member of SWOG, I believe. The Alliance trial, is Dr. Sai here? I don't know if you want to say anything about that. Yeah,
The Zoom people won't be able to hear you.
yeah.
We have about 20 participants online.
This is a yeah, well, I'm sorry, I apologize for calling you unannounced, but I want to give you your opportunity.
No worries, I can be brief. So the PI for this study is Alex Shushari over at Sloan Kettering. And this is a trial of adjuvant cabozantinib plus PD-1 for resected mucosal melanoma. There also is a small cohort for unresectable disease of that same combination. So their projected accrual is around 99 or 100 patients, somewhere in that neighborhood. They have accrued, I believe, a total of 14 patients across the nation at the moment. There are several SWOG sites that are currently in activation, and there's currently one patient who has been treated, and that is out of USC, I believe, with Dr. Gino Yin. And there's several sites within SWOG that are in the process of starting up, including ours and MD Anderson, I believe. Thank you.
Seems like a very good and interesting trial to me, and so I wanted to give her an opportunity to promote it. Next trial that we see on here is the 6174. I don't know if Dr. Sue is here. No. Okay. But at any rate, 6174 has met its accrual goal. This is adjuvant Pembro in Merkel cell carcinomas. And the discussion has been about what they're going to do for correlative studies, whether they will be allowed to accrue more patients or not. And I don't know the answer to that. 6141 is Ipi-Nivo with or without GM-CSF, and Dr. Kim is the SWOG champion for that.
David. Yes.
Do you want to go through pet stop first and then maybe we go through 6141 after that?
Yeah.
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 Finish your deck.
All right. All right. well, we'll skip this for a little bit. And then the next one is the PET stop trial. And this one I wanted to take a minute or two on because its accrual is lagging right now. It's about 1 to 3 per month. The goal is to have about 5 per month. They've accrued 32 out of 151 patients. For those of you who are not familiar, this is a biomarker-driven early discontinuation, and the biomarker is PET scans. But one of the things that they want to look at also is ctDNA, and that's being added in as a potential marker. The hypothesis, I think we skipped over a little bit, but it's that advanced melanoma patients with disease control by scans for 1 year on anti-PD-1 therapy can successfully discontinue the treatment. And this is if they have a negative PET-CT or a negative biopsy for residual disease. And you can see a little bit of the rationale on this slide here, which is a trial, very small trial that Dr. Gibney and his colleagues did, showing that that people who discontinue early can do as well or nominally as well as people who complete the entire session. Let's see, which button do I push? Yeah, this goes back, this goes forward. Okay, and this is keynote 06, just basically showing that patients who completed the protocol, did and had complete responses did very well. This is showing that people who stop treatment because of toxicity, i.e. early, do just as well as people who complete the entire year. And this is just showing that if you have a CR or a PR or you're PET negative after 1 year, you can see whether you took Nivo-Ipi or Nivo alone, you have a very good survival compared to. All right, so when can patients safely stop PD-1 after demonstrating a deep response? We've been going backwards because we were a little bit ahead, so I'm going to skip forward to these. We talked about the hypothesis. The benefits, of course, would be reduced risk of late adverse events, but a lot of the benefit is the reduced burden of care on the healthcare system and an improved patient experience. Dr. Takyao is the SWOG champion on this. Jeff Gibney is the overall study chair. This is the schema. It's just to go over the fact that you can see, and it's a little bit complicated. There's a pre-registration stage. And then if they have a PET scan that is negative for any hypermetabolic lesions, then they go on to discontinue therapy and get followed up. If they have a PET scan that's positive for a hypermetabolic lesion or more than one, and they have biopsies and the biopsies are negative, they can also go on to just observation. But if the biopsy is positive or the PET scan is more diffusely positive, then they continue treatment for another year. So this is arm A is the discontinuation arm. Arm B is the continue arm. Do you have a question now? Yeah.
I just wanted to say, we opened it, and it's been a really great study to have. That there's been an amendment recently that's making this step
Yes.
easier. Oh, there you go. I'm gonna.
Yes. Yes. Yes, there has been an amendment to try to make it easier to accrue to this trial. One is that Nivo-Rela was not included originally, and Nivo-Rela is included now. And that's an update. Before it was just any PD-1 treatment other than Nivo-Rela. And they have to have CR/PR, through 1 year of treatment, and they can't have had any bad toxicities. And one stress point is that you have to identify patients before that 52-week scan comes up, because there's a fairly tight window, and you have to, you have to be on it about looking for that. Statistics, I think, no offense, but I'll just zip through the statistics unless you have any objection. Okay. The sample size is 150 people, and they expect most people to be assigned to arm A. And the target is that more than 90% of the patients who are on arm A will be event-free for at least 12 months after you stop the PD-1. So that's their target. Now, as I mentioned, ctDNA is now a planned biomarker. It was not in the original study, but it is planned now. And I don't have a lot of details about how they're planning to do that. But at any rate, I think these are things that we've already talked about. This is just to say that there really aren't any competing studies in the US. There are other studies in the world. And this is just my chance to show the ECOG Akron flag, while I was here. But all right, so any questions about this or comments? No.
Oncologists, if they have a good response, many times, sometimes they stop after 1 year, so do you think doctors don't worry about the clinical trial, they will stop after 1 year? Do you think that's the reason why it's slow?
Well, I wonder about that. I don't know that, but I know the temptation has been strong, if they've had a negative PET scan at about a year, to stop them. And I don't know what percentage of people are actually doing that, but I would say that that's a concern. Yes.
Yeah, and I think, we have that habit, but we don't have great data whether that's the right thing to do.
Yeah.
Alison Bitoff-Warner from MSKCC did a retrospective study from a single institution that I thought was very interesting, because they had the custom there to stop at CR, and they showed that doing that and not going 2 years as they did on trial, that their relapse rates were higher. So, somewhere in between is probably better. Is it the same for every person? And especially because some people do have late toxicity. So I think it's a great survivorship question, because for me, having that discussion when to stop, you kind of don't have a lot to say. So it'd be great to have that more data. And I love that there are correlatives that hopefully will even help other studies in the future.
Yeah.
David, remind me the number for PET stop again. It's EA.
6192. It's a typo
In the booklet? Okay,
Yeah,
okay.
in the book,
So-
it's a typo.
So we have a question from one of our Zoom attendees. Will patients treated on investigational agents in the adjuvant setting be allowed on 6192? Can this be any anti-PD-1 or only the approved one? So this is a metastatic trial, basically.
Yeah,
So it won't
yeah.
allow the adjuvant.
No, no.
Will it allow investigational?
No.
Okay.
Yeah, and
That addresses.
they had thought to include maybe like T-VEC Pembro, because even though it's not approved, many people do use it. And maybe we'll consider that for the next amendment, but right now it's only approved agents.
Thank you so much, David.
All right, thanks. Dr. Karen?
And we are running short on time, but we'll just power through. I understand there's no meeting in this room afterwards, so we'll keep going. Next is Dr. Kevin Kim, who will give us the SWOG champion update for 6141. It's a number salad up here. There we go.
Okay, everyone, can you see the slides here? Okay. This is the old trial. We started 2015, so I thought it'd be a good idea to kind of give a little reminder before we talk about the current status of it. This is a randomized phase 2/3 study of nivolumab plus ipilimumab plus GM-CSF, sagrolimumab versus nivo-ipi combinations in unresectable disease. And the base on this trial was because of these prior phase 2 studies, randomized studies, combining ipilimumab plus GM-CSF had such better overall survival over single agent ipilimumab. Even though it's only about 245 patients, looks very interesting overall survival benefit. So can we add GM-CSF to increase antigen presentations and activations of T cells and dendritic cells to make better clinical benefit over nivo-ipi combinations? This is a randomization first-line trial treatment, and patient Arm A is receiving nivo-ipi traditional dose, the 3 milligrams per kilograms of ipi plus 1 milligram per kilograms of nivolumab, plus sagrolimumab daily 1 to 14 days straight subcutaneous injections every 3-week cycle, versus Arm B is typical current standard every 3 weeks of nivo-ipi combinations, but the maintenance is actually every 3 weeks. To conform with the Arm A. Primary objective is overall survival of this triple combination versus double combination. Secondary endpoint is PFS and tolerability, safety, toxicity, and immune-related response rate and RECIST criteria response rate. Eligibility of patients, once again, this is the stage 3-4 melanoma, and patients should be treatment naive, except adjuvant PD-1 CTLA-4 antibody treatment is allowable as long as last dose was more than 1 year prior to the registration. And no PD-1 or the ipilimumab in the metastatic setting. And original design was quite ambitious at the time. It's 50% improvement over survival. But at the time, the assumption was we thought the median survival of the patient getting standard treatment was 2 years. But then since then, we found almost like 5 years as a median survival now. So you have to redesign the clinical trial. So after 250 patient phase 2 study was the enrolled and analyzed, the design was modified. So now new design is that the assumption of the improvement of this triple combination has a ratio of 0.67. So from 50%, the survival rate is up to a 63% at the long-term 5-year survival rate. And after 265 patients death I reported, then there'll be a final analysis will be done. Total accrual goal was initially 400 for the whole trial. Now it's up to 600 because of the change of the statistics. And there's long delay because of the after phase 2 study portion is done. There's a lot of design was modified. And finally, it was opened back up again about 2-3 years ago with a new design. So far, out of 600 goal, we have 407 patients enrolled into clinical trials. Last year, this year was 327. So about 80% enrolled since last year. And SWOG had 49 patients in the trial. So we are doing quite good. So with this rate, maybe in about 2 years, we'll be able to finish it. Then that'll make about 10-year anniversary of design of these clinical trials. Thanks. Any questions?
I'm going to say this is a great rollout that you have longer survival than Spain.
Yeah, absolutely. That's a good thing for patients. Thanks.
And Kevin, the sarcorammus is being provided, right? Okay, thank you. And, you know, pardon me for sort of glossing over S1801. I realize since the last meeting, I'm sure most of you guys realize, but we have had a publication with that study as well in the New England Journal of Medicine in March of this year. We had an oral plenary presentation at the Society for Surgical Oncology given by Mike Lowe. And then we also had an exploratory objectives or endpoints presentation at the Bridge meeting in December. Sorry for going backwards on that. Let me offer the microphone to Sam Guild in case there are any advocacy updates or announcements you would like to make. Okay. Okay. No slides though, right? Okay.
So my job is to be the patient voice. And so today I am going to bring you the voice of a patient. So to the researchers finding new ways to combat the terrible disease that is melanoma. My name is Dylan Slattery, and I was diagnosed with melanoma for the first time at 22. That was followed by surgery on my neck to remove the mole and test the lymph nodes in the area, leaving me with a 7-inch scar down the right side of my face. Margins were clear. Just 18 months later, I woke up with a golf ball-sized lump next to the scar. Many scans, tests, and biopsies revealed that I had stage 4 melanoma with tumors in my neck, lung, along multiple tumors in my liver and spine. At 23 years old, I was given less than 10% chance of survival. I had the BRAF mutation, which meant that I was a candidate for the experimental trial that included 4 rounds of IPI, followed by 4 weeks in the ICU, where I did high-dose interleukin-2 every 8 hours for as many rounds as my body could handle for a week at a time. In the ICU, I had many close calls. My body wanted to shut down, but thanks to tremendous support from family, friends, and a dedicated medical staff, my mind adopted a never quit attitude and a newfound purpose for life. The experimental trial allowed my body to fight off the disease, showing significant reduction of all tumors and eliminating most of them. More importantly, it bought me time. With the additional time, it allowed researchers like you to come forward with even more proven treatment options. Pembro, in my case, that allowed me to go back to work full time while still fighting the disease. We are still losing too many people filled with potential to impact and change the world to melanoma. I lost a friend to the disease when he was 21, and currently another friend with 2 young children had a reoccurrence and is fighting for her life. Thanks to researchers like you, you're giving us a chance, hope, and most importantly, belief. When I was given my prognosis of less than 10%, I looked at my parents and said, I only need 1% to have a chance. Every one of you in the room and on Zoom today represents that 1% chance. And if we can improve the odds by even a few percent every year, that means more people living to their potential. I cannot thank you all enough for the incredible outcome that I personally experienced because of you. You have given me an extra 9 years, and I can share with you that I've been NED for 6 of those. The world needs you, each and every one of you. Keep fighting and keep showing up. For those that have gone too soon, for those that are currently battling, and for those who will be told it doesn't look good. When I was diagnosed, I heard the now famous words of Stuart Scott when he said, when you die, you don't lose to cancer. You beat cancer by how you live, why you live, and the manner in which you live. The same is true for you. Live life. Thank you so much. I am eternally grateful. Dylan.
Thank you, Sam. That's maybe how we should have started this session, is just centering ourselves around the patient. We have one last slide to share here. And then I would like to ask anybody for whom this is perhaps your first SWOG Melanoma Committee meeting, if you're shy, don't worry, but if you'd like, please feel free to come up to the microphone and tell us your name and institution and your specialty, or if you're from pharma, please feel free. And then remind everybody that in about 2.5 hours, there is the reception here in the atrium. So please join us there and mingle. There is one last slide I just wanted to show, if we can show this. And not sure, Takia, if you wanted to maybe, as the organizer, say something. You want me to say something? Please feel free.
Yeah, we want you to save the date and expect an invitation soon. There's going to be a melanoma reception at ASCO. It'll be our second in our event. We had our inaugural event last year. And, you know, it's friends and colleagues from all over the world that will be there. This is the meeting where we all come together, and we look forward to seeing you. We are also really excited because this year, there will be a wine tasting from a Napa Valley winemaker and a melanoma survivor. So we're really excited that they're able to join us this year. Please come.
Thank you, Takia, for helping to pull this together. And for those of you putting it on your calendar, it's 8 to 11 p.m. Central Time. So hopefully it makes time for everybody's board meetings, and that is poster discussion day, I think. Any new members, new attendees who want to come up and introduce themselves? If not, I totally understand. Yes, please, please. New faculty member from Carmanos.
Hi, everyone. My name is Yusra. I'm an almost graduating fellow at Carmanos in Detroit, and I'll be joining on faculty there for melanoma and GU. It's exciting to be here, and I look forward to future meetings.
Great.
Thanks.
Welcome.
Thank you.
Okay, if no other takers. Welcome, Lillian. Welcome. All right, everybody. Well, that wraps our spring meeting. Thank you, everybody, for the attendance, the discussion, the questions. I'll be happy to stick around and mingle if anybody has questions, and then see you guys at reception in a couple of hours.